When performing any examination on the wards, it is important to understand any limitations a patient may have. Taking into account a patient's age, any comorbidities, and any recent surgery is crucial when beginning an examination. The more frail and elderly the patient, the more difficult it will be for them to move into the different positions that you may require. Due to other possible comorbidities, it may be extremely distressing for the patient to try and hold their breath. It is also important to try to not use any medical jargon during the examination and to always use language the patient can understand. Understanding this and tailoring your examination to each patient is crucial and will become easier with more practice and experience.
Hi there, my name is Ajit O'Brien and I'm a fourth year medical student and I'd like to do an examination of your heart today. Is that okay?
Yeah, that's fine.
Thank you. I will need you to undress from your waist up and need you to take your shoes and socks off and get up on the bed for me.
Okay, that's fine. Thank you.
As the patient is getting onto the couch, I am looking for any signs of discomfort. I am looking to see ease of movement and whether he is breathless. I then stand back and look at the patient as a whole. I am checking for any abnormalities such as discomfort at rest, generally unwell, pallor, tachypnea, any flushing, cyanosis, surgical scars, and any items of note around the bedside, such as intravenous infusions or whether the patient is on oxygen.
I'd like to have a look at your hands, please. Thank you.
In the hands, I am feeling the temperature, inspecting the palms for Janeway lesions, Osler nodes, and any signs of peripheral cyanosis. I then check for signs of xanthomata, any splinter hemorrhages, and check the capillary refill time. It is important to then inspect for clubbing. Examine the edges of the nail bed and the angle between the nail and the nail bed.
Thank you. I'd just like to assess a few pulses in the arms, just by start your radial pulse.
When examining the radial pulse, it is important to assess the rate and rhythm, and to allow at least 15 seconds to provide a good estimate of the patient's pulse rate. You may also take some time to examine the patient's breathing.
I'd like to just compare the pulses in both arms.
Palpate both radial pulses simultaneously, assessing any delay between the two and any difference in volume.
Thank you. I'll also be testing for a collapsing pulse.
If I suspect aortic regurgitation, I examine for a collapsing pulse. To detect a collapsing pulse, palpate the radial pulse with the base of your fingers and raise the arm vertically above the patient's head.
Thank you. Just going to be moving up and testing some of the other pulses in your arm.
I then move on to examine the brachial pulse. The brachial pulse is located medial to the biceps tendon at the antecubital fossa. This is used to assess the volume and the character of the pulse.
Thank you. I'll also need to test a few of the pulses in your neck as well.
To examine the carotid pulse, gently place the tips of your fingers between the larynx and the anterior border of the sternocleidomastoid muscle. When examining the carotid pulse, it is important to do it gently and to never assess both carotids simultaneously.
Thank you very much. I'd also like to have a look in your eyes as well. Thank you. Could you look up for me, please?
Examine the conjunctiva for signs of anemia and any petechiae,
Thank you.
the iris for a corneal arcus, and the eyelids for xanthelasmata.
And could you open your mouth for me?
Examine the mouth for dental hygiene and any signs of central cyanosis.
And stick your tongue out. And if you could bare your teeth as well, please. And show your gums. Thank you. Please relax. I just need to examine one of the veins in your neck. And then you turn your head to your left and rest your head back.
The internal jugular vein arises from the two heads of the sternocleidomastoid muscle. The JVP is the vertical height in centimeters between the upper limit of pulsation and the sternal angle. It is normally equal to or less than 3 centimeters.
Thank you.
The hepatojugular reflux test can be used to confirm it is a JVP.
I'm going to be applying some pressure to the right side of your abdomen. Okay, if you can keep your head in the same position.
The JVP is generally very difficult to identify and will become easier with experience and learning new techniques. Explain to the patient that you would wish to examine their chest. Inspect the precordium with the patient sitting at 45 degrees, with their shoulders horizontal and their arms by their side. Here you are looking for any surgical scars, visible apical pulsations, and any chest wall deformity.
I'm just going to be having a feel across your chest. Is that okay?
Yep.
Begin by locating the apex beat. The apex is normally located at the fifth intercostal space in the midclavicular line, unless displaced by enlargement. It is important to assess the character and any displacement. If you are unable to locate the apex beat, you can ask the patient to roll onto the left side. However, you will be unable to comment on the position of the apex.
If I could ask you to take a deep breath out for me and hold your breath.
To feel for a right ventricular heave, apply the heel of your hand firmly to the left parasternal area. Asking the patient to hold their breath on expiration will make this
Please
easier.
relax and breathe normally.
Palpating over the valvular areas both sides of the sternum using the flats of your fingers might identify a thrill.
Thank you very much. Oh yeah, I'm just going to listen to your heart now using the stethoscope. Is that alright?
Yep.
Thank you.
There are many methods for auscultation, and it is likely that you will develop your own. However, it is orthodox that auscultation of the heart should start at the apex, followed by the lower left sternal border and the upper left and right sternal borders. At each site, identify the first and second heart sounds, any additional sounds such as S3 and S4, and any possible murmurs. It is important to remember to palpate the carotid to identify S1 and to help identify and time a murmur. The pulsation of the carotid indicates systole.
Thank you.
If you suspect you hear a murmur, there are specific maneuvers you can get the patient to do and areas to listen to make the murmurs louder and clearer.
Hi there, I'll just be listening to your neck. Could you take a deep breath and hold your breath for me?
If you suspect aortic stenosis, auscultate over the carotids. This is the region where aortic stenosis is best heard and radiates to. This is also the area to listen for any possible carotid bruits. This is made easier by asking the patient to hold their breath.
Thank you. Breathe normally.
I then listen to the axilla. This is the area where the radiation of mitral regurgitation is best heard.
And if you could lean to your left for me.
I then listen over the apex and ask the patient to lean to the left side for the radiation of mitral stenosis.
Relax, please.
To complete my examination of the precordium, I listen to the left lower sternal edge with the patient sat forward, where the radiation of aortic regurgitation is best heard. Asking the patient to hold their breath on expiration can make this easier.
I'm now going to need you to sit forward for me. Could you take a deep breath in and out and hold your breath? I'll just be listening to your back now. When I place the stethoscope, please may you take a deep breath in and out for me.
Yep.
While the patient is in this position, it is important to listen to the lung bases for any pulmonary edema.
Thank you. And once more. Thank you very much. I'll just be having a feel to the bottom of your back now.
It is also important to palpate for any possible sacral edema.
Thank you. You may relax. I'll just be feeling some of the pulses in your feet.
It is important to palpate both the dorsalis pedis and the posterior tibial pulses. The dorsalis pedis pulse is best felt at the proximal extent of the groove between the first and second metatarsals. The posterior tibial pulse is located 2 centimeters below and posterior to the medial malleolus.
just be squeezing around your ankles. Let me know if there's any pain at all.
The ankles should be assessed for peripheral edema. Edema can be painful, so it is important to warn the patient before applying any pressure. It is important to track any edema. This can be done by applying gentle pressure along the tibia to where the edema ends.
And I just need to feel one of the other pulses in your leg. Is that okay?
Yep.
I need you to bend your right leg for me. Thank you. And now rest it down and let me take the weight.
The popliteal pulse lies posterior to the knee joint, at the level of the knee crease, deep in the popliteal fossa.
Thank you. I just need to feel some of the pulses in your groin. Is that okay?
Yep.
I need you to lower your shorts just to the level of your groin, please. Thank you very much. Please relax.
The femoral pulse lies just below the inguinal ligament, midway between the anterior superior iliac spine and the pubic symphysis.
Can I please feel the pulse in your arm at the same time?
When palpating the femoral artery, it is important to compare to the radial artery to assess any possible radiofemoral delay.
Thank you, Matt, very much. You may cover up.
It is also important to listen to bruits over both femoral arteries, using the diaphragm of your stethoscope.
Thank you very much. That concludes the examination. You may now put your clothes back on. Do you have any other questions for me?
No.
Thank you very much.
Thank you.
It is important to measure the blood pressure during every examination. If there is clinical suspicion, then examination of the abdomen is important. This includes palpation of the liver, palpation of the abdominal aorta, and auscultation of the renal arteries.